All right, party people, we are back at it with another one. Let's get it. All right, so we have a 33-year-old female with a UTI. Now, right here, the most likely culprit is E. coli. Now, of course, other organisms can cause UTI, but E. coli is the big one that you need to know. Now, as far as urine culture shows resistance to ampicillin, sensitivity to ceftriaxone. If they ask you, what is the mechanism of resistance? Here's how we're going to break this down. So ampicillin, amoxicillin, and penicillin are classic beta-lactams. These drugs are sensitive to beta-lactamases. These are also called penicillinases. Now, ceftriaxone, on the other hand, is a third-generation cephalosporin. This one is resistant to most beta-lactamases. So when you see resistance to ampicillin but sensitivity to ceftriaxone, not complicated. The organism is producing a beta-lactamase. This cleaves the beta-lactam ring. Your licensing exam might give you a bunch of option choices, and the one that you would select is production of a cleavage enzyme. That's another way of saying beta-lactamase. Your licensing exams also love to ask about cellulitis, skin infections, methicillin-sensitive Staph aureus. So if they give you a picture of cellulitis, the key point that you need to know is that 90% of community Staph aureus produce beta-lactamase. That's why you do not, I repeat, you do not treat cellulitis, impetigo, or other skin infections with ampicillin, amoxicillin, or penicillin. Those will not be effective because the staph will destroy them. You can use penicillin for group A strep pyogenes, but this is rare on your board exams. If staph infection is indicated and shown to you, penicillin is the wrong answer for your licensing exams. Now, as far as methicillin-sensitive versus methicillin-resistant Staph aureus, this is another trap that they can hit you with. Methicillin-sensitive Staph aureus already makes beta-lactamase. So when methicillin-sensitive becomes methicillin-resistant, it's not because of more beta-lactamase production. That makes no sense. The mechanism is different. MRSA has an altered penicillin binding protein. This is sometimes called P as in Peter, B as in beta, P as in Peter 2A. This is synthesis of a novel penicillin binding protein. If the question was to ask, why is Staph aureus resistant to methicillin, the answer would have been altered or novel penicillin binding protein. All right, so let's get back to methicillin-sensitive Staph aureus. Now, what works against MSSA? We choose a methicillin class beta-lactam, such as methicillin, dicloxacillin, this is given orally, flucloxacillin, this is IV, nafcillin/oxacillin. These are resistant to beta-lactamase, and it's due to their bulky side chains. So they still work against MSSA. Now let's spin the block. So, number one, ampicillin resistance plus ceftriaxone equals beta-lactamase production. More than 90% of methicillin-sensitive Staph aureus makes beta-lactamase. Therefore, you do not use ampicillin, amoxicillin, penicillin for skin infections. MRSA resistance is due to altered penicillin-binding proteins, not beta-lactamase. Methicillin class beta-lactams are beta-lactamase resistant. Therefore, you use them for methicillin-sensitive Staph aureus. Finally, mycoplasma has no peptidoglycan cell wall. Therefore, beta-lactams do not work. For mycoplasma, we will use a macrolide like azithromycin or a tetracycline like doxycycline. All right, that's it for this one. If you like the video, comment, share, subscribe. Feel free to leave a comment asking or requesting a topic that you'd like to have me cover. And check out my Substack linked in the description box below. Go crush it.